Welcome, everyone. I'm Amy Henriksen, and I'm a registered dietitian and medical affairs manager at Nestle Health Science. I will be moderating today's presentation, Dietary Management of EoE, More Than Just Food Allergen Avoidance. Financial support for this presentation was provided by Nestle Health Science. The views expressed are those of the presenter and do not necessarily represent Nestle's views. The material is accurate as of the date it was presented, and it's for educational purposes only and not intended as a substitute for medical advice. I'm very pleased to present today's speaker, Dr. Carina Venter. Dr. Venter is an associate professor of pediatrics, section of allergy and immunology at the Children's Hospital Colorado and University of Colorado Denver School of Medicine. She's the past chair of the International Network of Dietitians and Nutritionists in Allergy and a member of the American Academy of Allergy and Clinical Immunology, American College of Allergy and Clinical Immunology, European Academy of Allergy and Clinical Immunology, and the British Society of Allergy and Clinical Immunology. Dr. Venter is also a senior advisor to Food Allergy Research and Education, or FARE. She's a registered dietitian in the United Kingdom and the United States. She has publications in international journals, book chapters, and edited a book on food hypersensitivity. We are honored to have her presenting today. Welcome, Dr. Venter.
Thank you very much for that kind introduction. And before we get to the objectives of the presentation, I just need you to be aware of my disclosures, which I'll show you on the next slide. And so with that, we can go over to the objectives now. So I think you've heard the introduction, but really in my heart of hearts, I'm an allergy specialist dietitian. I love seeing patients. I love doing research in the field. Every single one of my research studies have been inspired by a question parents asked me, which I wasn't able to answer. And within the field of food allergy, I have a particular interest in the management of eosinophilic esophagitis. So I'm really pleased to present on the topic today. So we will define eosinophilic esophagitis, or EoE, including the preclinical presentations and the prevalence. We will describe evidence-based diet, therapy, and nutrition management of EoE. We will focus and discuss the role of elemental diet in the management of EoE, including practical guidance on how to initiate the elemental diet and how to support families for better compliance. And then we will discuss the role of the microbiome in EoE and how it correlates with disease activity. Don't hold your breath. There's only 3 studies that I can recommend or reference at this point in time, but we will definitely be highlighting those. So eosinophilic esophagitis, it has a very long and complex definition, but EoE represents a chronic immune antigen-mediated esophageal disease characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. So really what that means is that with EoE, we have inflammation in the esophagus, and that can present with difficulty to swallow. In extreme situations, it can cause obstruction of the esophagus, and particularly adults may have to go dilation. But it's really the inflammation in the esophagus that particularly characterize eosinophilic esophagitis. And for the most, we think that the inflammation is driven by antigens or allergens. Today, I'm really going to focus on the role of food allergens and in terms of driving the inflammation in EoE. But pollens can also play a role, particularly in teenagers and adults as well. So it is important to know that EoE is a rare disease. The estimated prevalence in the USA is about 26 people per 100,000. It's higher in males. It's higher in Caucasians compared to other races or ethnic groups. And it's also, the prevalence is higher in adults than children. That was interesting to me. I would have thought the prevalence is higher in children than adults, but the most recent published data from the US indicate higher prevalence in adults. So let's focus now on the diet therapy. So in 2020, the American Gastroenterology Association and the Joint Task Force from the American Academy of Allergy and Immunology published a practice parameter where they summarized all the available evidence around EoE. And I think what you can clearly see from this table is that for most of the recommendations, there wasn't really enough data to make a strong recommendation other than the use of topical steroids. And the quality of evidence was either very low, and in 2 cases it was moderate. And the moderate evidence related to the use of topical steroids for the treatment of EoE or the use of the elemental diet for the treatment of EoE. In particular, Montelukast and sodium chromoglycate, which is a mast cell stabilizer, they felt that they couldn't make any recommendation and that there clearly is a knowledge gap. So, and I think one of the reasons is it's so hard to actually randomize study participants to do these studies. So more often than not, studies have not been randomized. There's currently 2 randomized studies in the United States. In children, it's the PCORI-funded studies, and in adults, it's an NIH-funded study. But the data from these studies are not available yet. So we will discuss the role of the elemental diet, of the test-directed diet. I will just touch on that. And then the role of the empiric elimination diet. And with empiric elimination diet, we mean 1 food, 2 food, 4 food, or 6 food elimination. And I will go into more detail about what each one of these means. So let's look at the elemental diet and other diets in the management of EoE. So I've drawn a red line all across this slide, just to give you some sort of indication of where 15 will lie. Because it seems that in the management and diagnosis of eosinophilic disease, 15 is our magic number. And we say that if somebody has more than 15 or more eosinophils per high power field, which is the field within a microscope, then the patient is diagnosed with EoE. If the eosinophil count per high power field is less than 15, then there isn't a diagnosis of EoE, although I will show you later on that perhaps when we do clinical diagnosis, we don't just count the numbers and make a diagnosis. We also look at how the esophagus appear when we do endoscopies. But for these slides and for these studies, resolution of EoE was defined as less than 15 eosinophils per high power field. And if we look at the targeted elimination diet, so they've actually done skin prick tests, which is now sort of like frowned upon and not regularly used in clinical practice, to decide which foods to take out of the children's diet. We did empirical elimination diets, and for this study, it was mainly 4 food exclusion and 6 food exclusion diet. And then they looked at combined interventions. And this was indicating the mean eosinophil count in the study participants pre the intervention, and then this was the mean eosinophil count in the participants post-intervention. And as you can see, in all of these studies, there was a significant reduction in eosinophil count, and also that post-intervention, whether it was targeted elimination, empirical elimination diet, or a combined intervention, the mean eosinophil count post-intervention was below 15. Clearly, this is the mean eosinophil count, so we can't say from this it worked 100%, because within this group that had a mean eosinophil count of around 8, there still were some that had eosinophil counts above 15 post-interventions and some that had 0 eosinophils. So do take into account that this was just the mean eosinophil count. So if you can try to memorize this slide when we go on to the next slide, and we look at elemental diets. So all these studies use elemental diets for the diagnosis and management, or the management more so, of EoE. You can clearly see again we have a huge reduction in mean eosinophil counts between the pre-intervention and the post-intervention group. And as you can see in these cases, the mean eosinophil count post-intervention was very low, close to 2 in the majority of cases. So it's very clear elemental diets work in the management of EoE, but there are many factors that we need to take into account before we can actually instruct our patients to follow an elemental diet. So if we then go on to the next slide, we can see here that we can use elemental diets for EoE. It's almost 100% guaranteed to work. I think the safer number to give is somewhere between 90 and 95% of patients will improve, have eosinophil counts below 15 when we use an elemental diet. But we have to use elemental diets only as a single source of nutrients in select cases. Ideally, it also should be used only for a short period of time, and then we should actively reintroduce foods once remission is obtained. I previously worked in an institution where we did use elemental formulas, in a number of cases of children and particularly teenagers with eosinophilic esophagitis, where we just couldn't get them under control with empiric elimination diets. And although many people think that families struggle and children struggle to only take elemental formulas as a source of nutrition, quite often when these children that's gone through a long process of having to find a diagnosis and then struggling to find a way to manage them well, when we get them under remission on an elemental diet and their abdominal pain finally disappear, they do not really want to eat again. And this is why I want to make the point of to say that if you do decide to use an elemental diet, particularly in an older child, where you get rid of the symptoms, we have to actively start reintroducing foods and not give them too much of a honeymoon period on the elemental formula only, because it can be very hard to convince them to start eating again. So also try to feed the amino acid-based formula by mouth if possible at all. Once again, some children, they're so happy when the peg feed is finally placed. They don't have to eat. Food makes them sick. Food gives them tummy ache. So you put the peg in and they feel better. That can also be a struggle to then eventually get rid of the peg feed and try to get them to eat. I personally had an experience now many years ago where a 5-year-old actually came to sit on my lap. It wouldn't now happen in COVID times on clinic. And he whispered in my ear and said, "Please ask them not to take my peg away." Because again, this was a child with a very unhappy relationship with food, and he felt so much better on the elemental diet via peg feed that he just didn't want to get rid of the peg feed. And clearly, we worked as a family until we finally found a solution that worked for everybody. And we shouldn't forget that it's not just a 0 or 100 solution to use an elemental feed. Elemental formulas can be very successfully used alongside a 1 food, 2 food, 4 food, 6 food exclusion diet. It can also be used very successfully along a few foods diets. So we may want to put a child predominantly on the elemental feed, but we do allow perhaps 1 grain, 1 fruit, 1 meat and 1 vegetable into their diet. And once again, I love these cases where I can explain to a mom 10 different ways on how to feed a child an apple, or 10 different things we can do with oats, if that's allowed in the diet, because an apple is not just something we have to bite into. We can make frozen apple lollies, we can puree the apple, we can make apple crisps in the oven. And so it goes. And this is really, again, of course, I'm going to plug the role of the dietitian, but we really need to have dietitians involved in the care of these patients. So, there's a big role for elemental formulas. We know they work. We shouldn't rely on them too much. If we decide to use them, get the food back sooner than later. And don't forget that there is a role for elemental formulas within the context of empiric elimination diets or few foods diets. So if we then go to the next slide, practical tips for implementation of the elemental diet, I really have to highlight here the website of CHOC with great information for families and parents. I've slightly modified them, but you can download the information from their website. We cannot put families or a child on an elemental diet without educating them, getting them ready, getting the formula available. What we would practically do is to tell them about the range of elemental formulas out there, about the different kinds of flavors. We may give a sample of each flavor to see which flavor the child gets on best with. It's important to be an advocate, contact the school. If they go on summer camps, contact the people. I often speak to people doing summer camps in California, because many of our children here in Colorado like to go to California for horse riding summer camps. It's important to join a support group, but once again, perhaps carefully selecting the most appropriate support group for each particular family. Change family outings to things that are not food related, go skiing or go for a walk or go horse riding, rather than going to the child's favorite restaurant where they cannot eat anything. Don't make the child's favorite dishes, remove sweet treats and snacks from the house. Be positive, and try to get the whole family to be positive, mom, dad, grandparents, and siblings. Remind the child how good they feel on the diet. If the birthday is within the time period that they do the elemental trial, make a birthday cake from a hat where you put different decorations on. Give small rewards for meeting his or her nutritional goals. Encourage the child's siblings to be supportive. The worst thing that can happen is one child saying, why can we never eat food X? Just because he's on an elemental diet. So we've got to get the siblings to help and not judge or criticize. And the most important thing is the family have to stay united and supportive, as I've already highlighted. Then what to do if the child refuses the elemental drink? Because not every child is going to be very happy with their elemental feed, or, perhaps even having the peg feed. But if they have to take it orally, like I've already said, try different flavors. You can add additional flavors. Try smoothies. If they have one allowed fruit, you can make beautiful smoothies. I use an ice cream maker to make sort of like soft serve ice cream from the elemental formulas. Discuss possible inclusion of a few foods with the allergist or gastroenterologist. Do not give up after the child refuses the formula. Just as we say we have to try broccoli or Brussels sprouts perhaps 13, 16 or 17 times with a baby before they will accept the taste. Getting used to drinking elemental formulas and the particular taste and flavors may also take a bit of time. Definitely praise the child and offer small servings. We all know how, nobody wants to face a whole plate of Brussels sprouts, although that is one of my favorite vegetables. And perhaps if you start with one or two, that would be better. And the same with elemental formulas, start with small servings, offered in their own special cup or a special flask, or in England, I'd say, in this special beaker. But whatever you call the cup or the flask, choose one with colorful outside. I know for a fact that my daughter would want to have a purple cup if she was an elemental formula. So really work with each particular child. So then the elemental formula, they ask, can they only have food? This slide is probably the most difficult task I ever have as a dietitian, because my whole attitude about food and eating sort of like goes against advising the foods on the slide. But what we have to remember is these kids, if they're on elemental only without any few foods added, these are the only foods that they can have. So they can have some candies like Dum Dum lollipops. They can have rock candy, Chom's cotton candy, Smarties brand candy. It's the sugar-based one, as you can buy here in the States. In Europe and the United Kingdom, Smarties are actually chocolate candy. So that's not the Smarties we refer to. It's the Smarties here in the States. fun dips and also pixie sticks. And I'm sure in each particular country, there may be different kinds of sugar-based candies, perhaps with artificial colors and artificial sweetener, which means there's no protein in that the children can eat. But that's another reason why really, if we can put a few foods back in the diet, it can make all the difference, because we do not want the child to solely rely on these foods. But for a special time in a child's life, when they're only on elemental, there is a role for these foods. So on the other side of elemental diets, we also have the empiric elimination diet. And so this slide, I promise you, every time I give a talk on EoE, I scrutinize all the literature, try to add another study to my slide. But this is the most up-to-date summary of all the diet trials we have on eosinophilic esophagitis. Now, again, in my simple mind, I think if we have a graph where we do 1 food exclusion, 2 food, 4 food, and 6 food exclusion, the graph would have a straight upward line. With the more foods we take out, the more likely or the higher percentage of people responding to the diet. But interestingly, as you can see from this slide, this is clearly not the case. So here we have the 1 food exclusion diet only conducted in children in the States. We have the 2 food only ever conducted in Spain in children and adults. We have the 4 food conducted in children and adults, both in the US and Spain. And then when you look at the 6 food exclusion diet, there is some studies conducted in children, but the majority of studies have been conducted in adults, with 1 study from Australia as well. And perhaps that may explain why we don't just see a straight line, because we have children, we have adults, we have children from different countries, adults from different countries, and none of these studies have been studying the underlying diet. And I think, when we get to the microbiome slide, it clearly shows that the underlying diet and diet changes can affect the gut microbiome as well as the esophageal microbiome, and perhaps which can then again affect disease outcomes. And so perhaps if we study the underlying diet, we can also understand better why we see better improvement in some studies versus other studies using similar diet interventions. But I'm using the word similar diet interventions because not all diet trials use the exact same format, even though they all may use the term 2 food exclusion, 1 food, 4 food, or 6 food. And so let's just now get to the definition. A 1 food exclusion diet normally refers to milk avoidance. A 2 food exclusion diet refers to milk and wheat avoidance. The 4 food exclusion diet refers to milk, egg, wheat, and soy avoidance. So milk, egg, wheat, and soy. And then the 6 food exclusion diet refers to all the foods listed here: the milk allergens, egg, wheat, fish and shellfish, peanut, soy, and tree nuts. But as we all know, there's at least 9 different tree nuts, so perhaps it's not as simple as a 6 food exclusion diet. And there's almost 700 species of edible foods in the sea. So perhaps, it's way more than just a simple 6 food exclusion. But this is really what we use: milk, egg, wheat, fish and shellfish, peanut, soy, and tree nuts. So I want to explain the differences between some studies. So far, milk avoidance in all these studies have been similar, excluding cow's milk, as well as goat's milk, sheep's milk, and other cross-reactive milk such as ewe's milk, or perhaps even camel or dromedary milk. All studies are similar in terms of egg avoidance, avoiding eggs from chicken, duck, and goose. When it comes to wheat, that's where we first run into trouble. In the United States, the majority of studies, it's not necessarily everybody's clinical practice, but the majority of studies use wheat exclusion only, whereas the studies conducted in Europe exclude wheat as well as barley, rye, and oats. So it's really gluten-containing grains that's being avoided. Most studies avoid all seafood. In America, if we avoid peanut, it's peanut only. In Europe, it's peanut as well as soy because of the high level of cross-reactivity we get between peanut and soy in Europe, which is really aeroallergen driven. And then when we do soy avoidance in the US, it's soy only. But again, in Europe, they tend to avoid soy as well as legumes, such as lentils, chickpeas, peas, beans, as well as peanuts, because once again of the cross-reactive specificity between soy and peanuts. In the States, they avoid all tree nuts, similar in Europe. And then the studies, particularly those conducted in Spain, would also avoid food allergens known to cause oral allergy syndrome, where patients have oral allergy syndrome or participants. So if they sensitize to birch pollen, in Spain, they may also avoid apple, for example, or peach. And in the studies in Spain, they also advise study participants to avoid anything that may contain or produced in a factory or could be contaminated with, whereas the American studies don't actually clearly state whether they instructed participants to avoid foods that could be contaminated. Now, in terms of clinical or practical diet interventions, this is a big deal, because if in America, if we ask a child or an adult to go on a 6-food exclusion diet and avoid anything with a may contain statement on, there's only one bread available in the whole of the US that they can include in their diet. And if they're unfortunate enough to have rice F5 alongside the EoE, then there are no breads available in the whole of the United States that they can eat. So once again, important to get a dietitian involved in the clinical management, because we know these little details. So which foods trigger EoE? And I wish I had just a very simple answer, but we could actually group the foods causing EoE together. So if we look on this side of the slides and we look at the adults, you can see that in the majority of the adult studies, wheat, milk, and wheat again came up as the top foods triggering EoE in adults. When we look at children, milk always gets the winning prize. So here in pediatric studies, doesn't matter where in the world they've been conducted, it's milk, and milk, followed by either wheat or egg. This is just one case study that was written up from Spain, and no surprise that legumes was an issue, once again, probably because of the cross-reactivity with other nuts, peanuts, and also some aeroallergen involvement. So with children, I think we're safe to say milk is the number one trigger. With adults, it could be milk or wheat. So which dietary treatment? Now, I'm not going to spend too much time on this slide, because whether we go for an elemental diet, an empiric elimination diet, or if you still practice skin test directed diets, there's advantages and there's disadvantages. And just looking at the table like this doesn't tell us what is going to work for a particular patient or study participant. And so I think I should actually cover this slide up with saying it really depends on each patient, and we really should focus on patient care and choose what's best for the family. So in terms of the elemental diet, the one that I will highlight is socially, it's difficult to cope with the diet. It can have effects on quality of life. With the empiric elimination diet, we only avoid specific food, but the disadvantage is that they really need a high level of dietary education, and they need to read every food label of foods that they are consuming. And the skin test directed diet could be removal of specific foods. So it may be a few foods if the child is only sensitized to milk or egg, for example. But like I said, this method of diagnosis is currently being frowned on. But if it is, for example, an adult with oral allergy syndrome, he may come up to a whole lot of nuts, fruits, and vegetables, which would mean that a number of foods are being taken out of the diet. So I do leave this for you for reference. Please visit the handout again afterwards. But I think the main message is every diet has got pluses and minuses, and we really should be talking to families about what would be best for them, as well as consulting the whole of the multidisciplinary medical team. So what to consider when choosing an elimination diet? So we're not talking elemental, we're talking food elimination. We have to think about, does the family have space and equipment to prepare foods? Like, I may suggest that they start baking rye bread if the medical team decided it's wheat exclusion only. But do they have a bread maker? I may suggest making wonderful smoothies and soft serve or sorbet ice creams in an ice cream maker. The ice cream maker in my house is really big, and people may not have the space for that, and they may not actually have a liquidizer or something that can make purees. Can the family afford freeze from foods? We know that these foods are about 20% more expensive than other foods. Does the family have access to a grocer selling freeze from foods? And quite often they may have to make a visit to 3 or 4 different grocers to do a monthly shopping. And Raquel Durbin, another well-known dietitian that I often work with, has published data showing that. We have to think about what the child is currently eating, what their current food preferences is, and what their nutritional status is. Often the children with EoE, they do like to drink a lot of milk. They have a lot of yogurt because it's something that goes down quite easily. But then often that is the trigger of their EoE. And so we really have to think about food preferences and are there locally available milk-free yogurts, that the child can buy or the family can buy. I know that that's not a problem here in the US. There's many different kinds of milk-free yogurts available, but that may not be the case if you're practicing in a different country. How willing and motivated is the family? I have families that just say, we're going to do a 6 food, we're going to make it work. Then we have other families where, do I really have to cut wheat out? Can I never have a sandwich again? So perhaps in those cases, you may want to start with a 1 food exclusion first. So really talk about to the family about, do they really want to make this work? And then also when we do food exclusion, we have to do the 1 endoscopy afterwards to see if they've improved. But that's only the beginning of the story, because if they improve, then we have to put the foods back 1 at a time or 1 group at a time with a repeat endoscopy. So, if we've done a 6 food exclusion diet, at minimum, it's going to be 7 endoscopies that the child will have to go through to try each new food that we've taken out. And so really also discuss that with the family. So this is a 1 food elimination diet, a study done by Dr. Wexler, and they had about 50% of the children, it was a pediatric study, improved on this diet. So about 51% went into remission, eosinophils less than 15 per high power field, and 49% had a failure with eosinophils equal or above 15. But what I really want you to show from a nutrition point of view is on the next slide. And so here you can see, I've mentioned earlier that I will touch on that we don't just look at eosinophil counts, we also look at what we refer to as the EREF. So it's edema, exudates, furrows, rings, and strictures in the esophagus. And without going into too much detail, you can see here that, all these factors or signs in the esophagus did improve on the elimination diet. What did not improve is the things that we as dietitians or those of us dealing with the dietary management have to look at, and that is early satiety didn't improve and feeding difficulties didn't improve. And so quite often you may find a family and the mother may say, the doctors are very happy with the following endoscopy after a 1 to 4, 6 food exclusion diet or elemental diet. But, my child is still complaining of early satiety. My child is still very reluctant to eat. We still have lots of issues with textures. And do you think we need to take more foods out of the diet? Clearly not the case if they've been on an elemental diet. But when they've been on 1, 2, 4, or 6 foods, families often wonder whether there's something else that's a trigger too. And it's important then to say that really to change the feeding behavior takes time, especially the abdominal pain as well. I feel we get everything under control, but my child may still have abdominal pain daily or from time to time. And just to reassure the family, that over time these things will improve. The next two slides basically just show the exact same picture, that the eosinophils may go down to 1 or 0, but we still have at least 2 kids that still got the abdominal pain, and we have 1 child that's still vomiting. And then here is data from Children's Colorado, when Dr. Vince Mercado was still a fellow here, really showing that the children have learned feeding behaviors. That takes time. I'm very fortunate here in Colorado where we have feeding therapy specialists that work with the children with eosinophilic esophagitis. So often that's not something that perhaps a physician or a dietitian with little experience in feeding behaviors can resolve, and getting the help of the feeding team once we've got the inflammation in the esophagus under control is definitely something that I would recommend. Then I always have to do the dietitian's bit, and here it comes. Allergens don't exist in isolation. We don't just take calcium out of a child's diet when we ask them to go on a milk-free diet. We don't just take carbohydrates out of the adult or child's diet when we ask them to go on a wheat-free diet. And so it's important, again, to bring the dietitian into the picture because if we're avoiding milk, protein, calcium intake, vitamin B12 intake goes down in the States where most of the milk is fortified with vitamin D. That can be an issue, perhaps less so in a country where the milk is not fortified. We have to remember that wheat also contains iron, B vitamins and fiber. Egg is a good source of protein. It's one of a few dietary sources of choline. Soy as well, taking protein out. But with soy, it's not so much perhaps the effect that soy itself has on nutritional intake, but the fact that if we take the soy out of the diet, we take many commercially produced products out because many foods do contain soy. And then the same with peanuts and fish and shellfish. So when we take fish, shellfish out of the diet, we take omega-3 fatty acids out of the diet. And so perhaps we need to think about an algae supplement in these children following a nutritional assessment. So really do think about the bigger picture, get the dietitian involved to think about the nutrients we're taking out, and then suitable substitutes, which I'm going to say about 3 more times in the talk. That is the main emphasis we should put on the dietary consultation is what can we eat? But then I also want to say people often think we put children on elimination diets and therefore they will be deficient in everything. That is not the case. Again, get a diet assessment. Perhaps you want to do some nutritional blood from the child. But in this case, looking at children with GERD and children with EoE, their protein intake was very similar. Their calcium intake was very similar. Both groups, however, had the calcium intake less than the recommended intake. The same with vitamin D. There wasn't a significant difference. The kids with vitamin D actually had more vitamin D in their diets than the kids without EoE. But again, both of these groups, the GERD kids and the kids with EoE, had vitamin D intake below than what is recommended. And that leads me nicely to the next slide, where I'm going to say to you that we really need better studies. I'll talk about vitamin D now, but this is one study where they showed that in children on elimination diet, the BMI Z-scores were lower in children following an elimination diet, and also lower amongst those with a lifetime proton pump inhibitor. So dietitians, I keep saying to the physicians I work with, we shouldn't just see the children on elimination diets. If they put children on steroids, if they put it on oral topical steroids, and if they put the children on proton pump inhibitors, so they need to get the children to us, and this is actually the bone mineral density Z-scores, so it wasn't just BMI Z-scores. So the bone mineral density Z-scores in children were lower if they were on an elimination diet, as well as the children on a PPI. The bone mineral density was not associated by steroid use. And so perhaps in these children on proton pump inhibitors, even though we don't take foods out of their diet, we still need to make sure that they get adequate vitamin D and calcium in their diet. And this is a systematic review that was recently published in Pediatric Allergy and Immunology, and they concluded there is limited published literature on vitamin deficiencies associated with EoE, both pre and post-intervention. The limited diet on vitamin D suggests that insufficiency or deficiency may be present in these patients. But if you now remember what I showed you on the next slide, there was just low vitamin D intake all over. It wasn't particularly relating to the EoE. And so when we want to look at nutritional status and nutritional intake in children with EoE, we absolutely must have a control group to put it into perspective. And many of the published data don't have that control group. So it may not necessarily just be an EoE related issue. It may just be that children don't have enough vitamin D in their diet. And therefore, we need better nutrition studies in children with EoE, but do keep an eye on the calcium and on the vitamin D. In children with food allergies, so this is really a combined group of children with IgE-mediated food allergies, children with F5. The majority of the children had EoE. All the children that I fed into the study had EoE. And what we showed was really looking at an international level that children with food allergies are underweight, but they're also normal weight and they're also overweight. Their growth is often impaired. So two things you have to take from this. Children with food allergies have growth or height or length faltering before they lose weight. So just doing weight in an allergy clinic or gastro clinic is not good enough. We need to look at the height. Secondly, don't just assume a child is underweight because they have EoE. Because within EoE, we see all three groups, underweight, normal weight, and overweight. So again, a good nutritional assessment in these children are crucial because you may be surprised when you put a child on a 6-food elimination diet where you have to put as equal amount of emphasis on healthy eating and not over consumption of calories as in another child on a 6-food elimination diet where your focus may be really getting sufficient calcium and protein into the child. So then growth. It is true that often in EoE, we see children with growth or length or height faltering, however you prefer to refer to that. And in these studies in children with EoE, as well as children with IgE-mediated food allergies and children with F5, we do see that elemental diet opposed to an extensively hydrolyzed formulas are better for height catch-up. And so here you can see all the EoE studies mention that weight gain has resolved, growth has resolved. And so perhaps if you do have a child where you are concerned about nutritional intake as well as growth, height and weight, you may want to really think about using an elemental formula, even if it's just initially to support whatever else nutritional intake the child is allowed to have. And then, again, my particular interest is immunonutrition. I'm very pleased that I am the chair of the EAACI, so the European Academy of Allergy, a working group on immunomodulation and nutrition, because yes, food is important to make sure our nutritional status is as optimal as possible, but food also has a potential very inflammatory and anti-inflammatory effect. And so this is a study published by a very good friend of mine, Werber Vlieg-Boerstra from the Netherlands, where they showed that if you look at number of eosinophils versus diet quality or the diet inflammatory potential, we saw reduced counts of eosinophils in adults eating rice, iron, fiber, soy, magnesium, vegetables, and yogurt. And funny enough, I've just published data showing that if maternal intake of pregnancy is high in vegetables and yogurt, we see less allergy outcomes in the infant. So perhaps there's definitely something to say for an allergy or less inflammatory potential of having a more varied diet with vegetables and yogurt. But then we also see an increased count of eosinophils associated with higher intake of phosphorus, B12, meat. So I think B12 and phosphorus is just an indication of the high meat intake, fried food, so the stir-fry oil and the sunflower oil, and also total fat. So, perhaps one day we will get to the point where we will do the empiric elimination diet, but there will an additional aspect to it where we will also look at frying of food, high fat intake, and perhaps focusing more on plant-based eating than just high intake of meat. And this is my own data from the United Kingdom, which I haven't published, but just to show that if we put participants on a 6-food elimination diet, their fruit and vegetable intake can increase, which is good. Convenience food and processed meat intake can go down, which is good. Alcohol intake may stay the same. And again, with this participant free, I didn't change much in terms of fruit and vegetables. The participant bought all the free from food, so perhaps I could have done a better job by explaining about recipes and cooking at home. Processed meat intake still stays the same. Participants said they checked every label to make sure that there's no added lactose to any of the luncheon meats they were buying, but the alcohol intake did go down. And so really this is just a slide to show, don't just focus on the allergens. This is really our opportunity to give advice on getting the wider diet better. Also remember that it's not just always about eosinophil counts and nutrients, but we also need to look at quality of life. So in this study, which is the CORE data that was presented at the DDW in 2019 and not published yet, they showed that histological improvement, the eosinophil count improvement, was pretty similar in children on a 4-food exclusion diet versus a 1-food exclusion diet. However, the quality of life in children on the 1-food exclusion diet was much better. So we also need to take that arm or aspect of dietary management into account. Then getting practical, I am going to try and finish in time. I will go through the next slide. We have to talk about food labels, hidden allergens in food, suitable replacement food. Second time I'm highlighting this, and then ensure nutritional adequacy. This is a paper I published with Dr. Antonella Chiamperoni from CHOP. So you can look at the paper in terms of, what to discuss. And again, similar thing, we need to talk about avoidance, what they can eat. What I do want to talk about here is the online resources. I spend a lot of time in my EoE consultation showing them different websites, showing them information that they can download, and showing them pictures of suitable products so that when they do go shopping, they do know what to look out for. So practical tips. Shopping can be time-consuming and stressful. Help people, to say which grocer they can go to, talk about, particular brand names that may work well, show them pictures, as I've already said. They help them to develop recipes or give them recipes so they can cook in batches and freeze, stock up on shelf-stable items, carry a chef card when they go and eat out, focus again on what they can eat. Third time now I'm highlighting that. Plan in advance. Everybody that's ever tried to lose weight will know things go bad when you haven't planned, you're hungry, and there's nothing suitable to eat. The same applies to children and adults with EoE. We have to make sure that they have suitable snacks, that foods are packed for trips, when they travel on airplanes and social occasions. And we also need to, most important role of the dietitian is look at what they're currently eating, adapt that. So perhaps they eat a wheat-based grain. Well, we can recommend a corn-based cereal that is suitable to eat. So that's really where dietitians, again, can play an important role. We do have to monitor. We need to monitor by endoscopy. We also need to monitor nutritional intake. We may want to do nutritional labs. And we also need to keep an eye on height and weight, as well as feeding skills and food acceptance. People always ask me, should we start at the bottom, go 1, 2, 4, and 6, or should we really just start at 6 and then reintroduce? So this study from Spain showed that if we do 2, 4, then 6 food elimination diet, we have slightly less endoscopies than when we start with a 6 food elimination diet. But I really want to say This is great data. These guys in Spain, Alfredo Lucendo and his team, doing amazing work. But when we have to decide whether we're stepping up or just starting on fixed food, it's really up to each individual family. And then reintroduction protocol. So now once you've got remission, do you put just milk back? Do you put the whole of the milk group back? Do you put, if you've done elemental diet, do you do just apples, then just pears, then just peaches, or do we do fruits, then vegetables, then grains? Again, that is a very individual decision. Each allergist have their own way that they like to do it, or gastroenterologists. Each family have different preferences. Some may start with the low allergens first because they think there's less chance of having an endoscopy showing inflammation. Others may say, let's just go for the high allergenic foods. Let's do milk first and see what the endoscopy show. If there's really concern about nutritional intake, we may start with the higher calorific foods first and work our way down to the lower calorific ones. But then you're always going to get the child who would say, I just want to have this food back in my diet. And that may sway us on how we order the foods that we reintroduce in the diet. So the microbiome in the last few minutes, this is not people with EoE, but just to show once again about PPI. It's not just a benign treatment. I've showed now how it affects bone mineral density. It also reduced the gut microbiome diversity in terms of the Shannon diversity, and it also changed microbial taxa. And from an IgE food allergy point of view, it has been shown that increased Shannon diversity is associated with more short-chain fatty acid production, upregulation of the T regulatory cells, and therefore less food allergy development. So we don't have that data for EoE yet, but I do think it's important to always look after the gut microbiome diversity when we can, and be aware that PPI can reduce it. So perhaps there's a study needs doing PPI alongside increased fruit and vegetable and whole grain intake. Then the next slide actually looks at the microbiome of patients with EoE, and it's interesting that the PPI and the food exclusion diet, any kind of food exclusion diet, had a similar effect on the esophageal microbiome. So we're not gut microbiome, it's the esophageal microbiome. And no surprise, because I've showed PPI reduce your gut microbiome diversity. It's doing the same in the esophagus. Taking foods out of somebody's diet will reduce their gut microbiome diversity as well. And here we show it for the esophageal gut microbiome. And steroids had less of an effect on the gut microbiome diversity. And then this is a study from CHOP showing that taking foods out of the diet, interestingly, didn't affect the gut microbiome that much, but putting foods back in the diet did actually change particularly two species of the esophagus. So there seems to be the effect of taking things out and starting certain treatments, and then there could be an additional effect when we start putting foods back. We really need to learn so much more about the esophageal microbiome. And then the final slide on the microbiome is the data, again from the group in Spain, showing that the microbial abundance, so the number and type of microorganisms went down. It's not exactly similar to diversity, but same story, where we take things out, we have less diversity, or we take things out and we have less abundance. And I'm not going to show all of those figures in this paper for you today. You're very welcome to have a look at it. But they clearly showed that as the esophageal microbiome changes, so does the innate immune system as well. So showing us if we change treatment in the esophagus, we change the microbiome, and alongside that, we also change the immune indexes. Allergy is an epithelial disease. It's the epithelial of the skin, of the gut, of the lungs, and of the esophagus that we need to look after. And if we want to look after the epithelial, we really need to start with the microbiome in the gut, the skin, the lungs, and the esophagus. And food affects the microbiome. So lots of really good studies waiting to happen in the field of EoE. And hopefully in a few years, I'll be able to share more data with you. This is a paper. If you don't have a dietitian in clinic, I cannot train you to be a dietitian in an hour, as much as I would love to. But this has got wonderful appendices on how to do different kinds of exclusion diets that you can print off and give to your patients. And so with that, I would really like to thank you. I'm happy to stay on for questions. If there are many questions, thank you for your time.
Dr. Venter, thank you so much. That was an excellent presentation. We do have a few questions, and it looks like we have just a couple minutes. So I have a question from Kimberly, who says, I have an adult patient who's been following an elimination diet. She only has been able to introduce 2 of the 8 allergens. Is there any well-done research supporting the use of elemental diet in adult populations?
Yes. It has been used in adults very successfully, particularly the team from Salt Lake City has done research on that. It's also been used in some of the Spanish studies. I know that the majority of elemental formulas, if you want to call it that, indicate up to 10 years of age, but there's no reason why it can't be using very successfully in adults. And I've used it myself in clinical practice.
Okay, great. Thank you very much. I have a question from Sharon, a very timely question from Sharon. Any data on EoE and COVID for children?
Not that I'm aware of. I actually did search last night. I couldn't find anything. But, I know that over the next few months, we're going to see some fascinating data about COVID and the gut microbiome. And hopefully we'll get some data on COVID, EoE, and the esophageal microbiome as well.
Great. Thank you for that. I have a question from Jennifer. With a soy allergy, do you exclude soybean oil or just soy protein?
No, don't avoid soybean oil. We just avoid soy protein.
Great.
There's a debate about the texturized vegetable protein because it is soy-derived. Initially, when I do that initial elimination, I do take that out just because I'm not 100% sure that it's okay to have. But when we start doing reintroduction and we open up the diet, even if soy is their triggered food, I would then actually allow them to have the texturized vegetable protein, but not in that initial stage when I really want to be as strict as possible.
Great, thank you. We have a question from Trish. Do you monitor for vitamin and mineral deficiencies? If so, which labs and how often?
That again is very individual, depending on, whether I work with a gastroenterologist or an allergist. But the labs that we would normally run really is vitamin D, calcium, and iron, where we do both HB or hemoglobin and ferritin. So that would be what we do. But I am working with a group through the American Academy of Allergy, where we're writing a paper now on how to monitor nutritional deficiencies in children with F5, EoE, and IgE-mediated food allergy, because I think we definitely need some guidance and some standardization on what we do. But being a dietitian, I would say that sequential diet histories and analysis of those is probably the best way to find out timely if there's any nutritional issues that needs to be addressed.
Great, thank you very much. I have a question from Amanda, who asks, how do you counsel families regarding cross-contact? I.e., do you recommend that they avoid cross-contact when preparing foods at home? What do you recommend for packaged foods with or without cautionary statements?
I think if there's EoE experts in the audience, half of them will now agree with me, the other half may not. But here's my take on it. We honestly do not know whether we need to avoid things that could possibly be contaminated, either at home or, in a factory. Again, similar to what I said about the texturized vegetable protein, in our initial avoidance of food, trying to get a clean endoscopy, we are very strict. We will say, in the majority of cases, sometimes not, but majority of cases, to avoid things that may be contaminated in production. When we talk about contamination at home, again, little bit over the top, but talk about different chopping boards, perhaps using different toasters. But as we are getting on top of the EoE and figuring out which foods are the culprits, we will also relax the advice we give about contamination either at home or on food labels.
Great. Thank you so much, Dr. Venter. We do have more questions, but we're out of time, unfortunately. I want to thank everyone for your time and attention today. On behalf of the Nestle Nutrition Institute, we hope you found this information useful to your practice. Enjoy the rest of your day, and please stay safe. Thank you.